So let's make a start. Good afternoon, everyone, or good morning if you're in Cuba. Welcome to the first seminar in the Institute of the Americas 2020 to 2021 Caribbean Seminar Series program. My name is Kate Quinn, and I'm Associate Professor of Caribbean History here at UCL Institute of the Americas, and I'm co-convener of the seminar series, along with my colleagues, Professor Gad Human and Dr. Steve Cushion, who's going to be acting as the virtual doorkeeper tonight. Caribbean Seminar Series has been running in various manifestations and in various institutional homes since the 1970s, when it was founded at the Institute of Commonwealth Studies. So tonight marks a new moment in the history of the series, as it's the first time, to my knowledge, that it's been held online. In these new pandemic conditions, it's particularly appropriate that the subject of tonight's discussion is Cuba and COVID-19. And we're particularly fortunate to be joined by our two esteemed speakers, Dr. Emily Morris, Research Fellow at UCL's Institute of the Americas and Coordinator of UCL's Cuba Research Network, and Professor Pedro Más Bermejo, Director of Epidemiology at the Cuban Ministry of Public Health and head of Cuba's COVID-19 National Technical Group. A very warm welcome to both, and in particular to Professor Más Bermejo for taking time out of his very busy schedule to share his experiences with us tonight. So before I hand over to the speakers, just some housekeeping and a word on the running order. First of all, please note that this session is being recorded. Also, please make sure that your microphones are muted whenever you're not speaking. And if you have a question about the talks, you can use the raise hand function, or you can type your question into the chat function. So please keep your questions short, on topic, and respectful. Our first speaker is going to be Emily Morris, who's going to provide...
But I can't say...
Oh, you're not on mute, Steve. Yeah. So Emily is going to provide a short overview of about 10 minutes before she will introduce Professor Más Bermejo, and we'll then open up to questions from the floor. And we're particularly keen to use this space as an opportunity to make connections for future research collaborations between scientists, epidemiologists, and health specialists in the UK with their counterparts in Cuba. So we'll particularly welcome questions and comments from that section of our audience tonight. So without further ado, a warm welcome to everybody, and I'll hand over to Dr. Emily Morris.
Hello, thank you very much for the invitation. Kate, is everybody hearing me okay? It's all working? Good. Yeah, I'm just going to give a brief bit of context. I'm going to talk for a very short amount of time. I just want to, just for people who are new to this whole subject, just describe very quickly about why we're looking at Cuba today. At the beginning of the COVID pandemic, I did an article, a very brief article with Ilan Kelman at the UCL disaster risk specialist. And we were looking at the case of Cuba. Both of us went to Cuba last year, talking to people who worked on disaster preparation. And we were wondering, how Cuba was going to perform. This would be a very interesting case study in this area, particularly because Cuba, of course, has the highest number of doctors per head in the world. It has a universal free health service. It has enormous research capacity, as we saw, and its disaster risk reduction and response is really second to none. They're very used to having hurricanes. They've also had various epidemics of different sorts that they've dealt with. But as we said then, that there's severe economic constraints on Cuba. There's not only the economy was sluggish even before the tightening of the US sanctions last year, which have become more and more ferocious since 2017, but particularly this year. And Cuba also, so there's been years of underinvestment. There's very crowded housing, very crowded transport, and there's also an aging population. The average age in Cuba is higher than it is in the UK. And so all of those things counted against it. And so you could see that the question was, is their disaster response and their health services and their research capacity and their capacity to mobilize strong enough to compensate for all of these challenges that they have. Now, I'm just going to very quickly just share my screen, and I just want to show you just how Cuba's performed. This chart here shows the daily cases. It's actually as a per head of population or whatever, but it shows that they had a first wave very clearly at the beginning, and actually in July reached 0 new cases one day. And so it looked like they'd conquered it. But like the rest of the world, that they were faced with the difficulty of the COVID pandemic, the COVID virus in particular, being that it lurks and then it recurs, and then you have outbreaks again. So since that time, it's returned to, well, according to the chart, same as previous levels, but you have to bear in mind that there are a lot more tests being done now than there were at the beginning. So it looks like they're still struggling to contain the virus. But if you look at another chart, this is from the Financial Times, which they have constantly updated. And this is the cumulative deaths per million. And that's by number of days since you had 3 total deaths per million. And you can see from here that Cuba is absolutely outstanding in the world. So very few countries have fewer than Cuba in this measure. So there's China down there, New Zealand, and we've all heard about these ones, not Curacao so much, but South Korea, New Zealand and China, the ones that are always talked about. But Cuba doesn't get mentioned, and it's actually doing, in comparative terms, incredibly well. This is a logarithmic scale. And here you have the United Kingdom competing at the top with the United States and Brazil. The lowest other country in the Americas is Uruguay, but even Uruguay has not matched Cuba's performance. So I just wanted to put that in there to underline the fact that Cuba's still struggling. It's still dangerous disease, but the performance has been exceptional. So this is really an opportunity to understand how that's been achieved and what has been learned by the scientists in Cuba in order to contribute to all of our understanding of the disease and the possibilities for research engagement with our Cuban colleagues. So that's all I want to say at the beginning. And so I just want to open up then now to Dr. Más Bermejo, who has been leading the Cuban response with a big team, I believe. And so it's a great privilege to have him here and a real opportunity for people to ask their questions after his presentation. Thank you.
Thank you, Emily. Professor Bermejo, you can share your screen now and unmute. Yeah, that's it.
May I?
Yeah, that's good.
May I go ahead?
Yes, please do.
Okay. Okay. Well, first, I want to say thank you very much for this invitation. I will try to show our experience in a very, very short time. That's very difficult because we have many things to show. And anyway, I will try to take a short time to show our ideas, because I am almost sure that we will have another opportunities to discuss different points, and this is just the first meeting. We will have for sure many more. Well, just to clarify, I am not the director of epidemiology in Cuba. I am working in the Tropical Medicine Institute in Cuba, and I am a coordinator of a very group of scientific people who belongs to the Ministry of Public Health, National Institute of Public Health, such as Tropical Medicine Institute, Hygiene and Epidemiology Institute, and many more. But this is a big deal to work with, and people of the University of Havana. We will show some of this point in the presentation. Well, okay, sorry. What happened? Well, this is not necessary because Emily explained very well that. Okay, I'm going to start with the main cause of death in Cuba in 2019 and in comparison with 2018. Well, as you can see, the three main causes of death in Cuba are the heart disease, cancer, and cerebrovascular disease. And of course, influenza or pneumonia, as you can see here, is an only communicable disease that is in the main cause of death in Cuba nowadays. But the main thing that I am trying to show you this data is because the COVID-19 is a syndemic. We have many non-communicable disease in the cause of death in Cuba, and that means that we started with the COVID with this very difficult situation, and that's a very important point that I want to show you briefly. Okay, let me explain to you briefly the Cuban strategy. Well, the first thing that the cases in Cuba started in March 11 from the tourists from Germany, and the tourists from Germany introduced the disease in Cuba in 11th of March. Well, the Cuban strategy is incorporate the national way door-to-door screening for persons presenting with fever and respiratory symptoms, carried out by primary healthcare professionals supported by medical science students. That is a very important point because I have to say that it's the main point of our experience. Go to the field to look at case or at contact of case. And that is a very important point. The second thing is the application using mobile device that they say now in Cuba, very popular, was developed for people to self-evaluate and indicate if they present symptoms, which then advise local health authority that the primary health care service provided can visit them at home. This is very important. The name is Autopesquisa in Spanish. It's available free of charge, and that is a very good point. And both components of the strategy have provided valuable complementary epidemiological information on presence of possible clinical case of COVID-19 and have opened a new possibility of surveillance and control of other diseases in the future. Okay. And going, continue with the strategy. The other thing is to gather specialists in biomedical, heart, and social science into a technical advisory team within the Ministry of Public Health. The team was tasked with periodically analyzing the epidemic situation, identifying problems, and recommendation solutions for different scenarios. And we will see the scenario later on. Among other things, this facilitated incorporation of new treatment and innovation for improving patient care, as well as timely prediction useful in guiding strategies for controlling the epidemic. And the contribution of the Cuban Institution of Science have been recognized in the media by government and health authorities. And I have to say that all the scientific group have a weekly meeting with the president, prime minister, and some different ministers and others, head of health institution. It's a weekly meeting that we presented some research outcomes, and sometimes we also look at the different data to help the decision do a good points and a good task. One thing that we are working from the very beginning, I mean April, is working with the prognostic models. with the researchers from the Havana University, the Faculty of Mathematics, in the dean of this faculty was in charge of this important thing, and they applied several prognostic models for the course of the epidemic in Cuba. And the third model means susceptible, infected, and recovered based on existing or ordinary, this is very important, ordinary differential equations has been used elsewhere and was chosen due to its simplicity and easy of interpretation. Now I will show you the expected cases curves, in the three theoretical possible scenarios: favorable, moderate, and critical. The active confirmed cases reported each day is registered in black. This is the first scenario according to the SIR model. And you can see the red is the worst, the green line is the middle, and the blue is was the best scenario. And the black line is the things that really happened during the beginning, it means April to August. But what happened is that at the beginning, the worst scenario means the red curve, we expected to have 4,885 active cases. And was a very, if this thing happens, was a very, very difficult situation for the health system, because the resources needed in terms of human resource, hospital beds, and so on. And this if this number of cases happens, was be on 14th of May. The second prognosis is 2,000, is the green line, 2,887 cases in June. And finally, the peak was in May, in 25 April with 847 cases. And that was very good for us to organize the health service, the personnel, the health doctors, nurses, and so on, that we need to clarify this. And this is what really happened. What is happening now? Well, you see, Emily showed the first part of the cure, and I don't want to go again with this. But what happened now is that the number of cases is almost the second wave, but we are in the second wave, and we not reached yet the peak that we have in the first wave, means 847 cases. And now the situation is getting better, because a big compromise of the government, despite the US blockade in this pandemic time, that is really, really, really very bad for us to find everything that we need for use in the people who are ill during the outbreak. Well, this is the real situation that we have on 25th of October. And you see, we have almost 7,000 cases. For us, it's a big challenge, but I know that many countries have 30,000, 20,000 in a day. But this is the all cases that were confirmed. We have that day we have 751, and recorded we have 6,029, and death just 128, means that is the real index is 1.92% of the death among the cases. It's very, very low if you compare with Latin America. If you compare with the world, that is 2.6 or something like that, it's a very, very good results according to the situation of the world. And the hospitalization and testing, we have one day, you see, we're doing around 8,000 PCR tests per day around. And in that day, 25th of October, we found 29 positive. And today we are doing 800,197 PCR tests. Means it is a lot. It's a big challenge to find money to buy everything. And we have, on the other hand, the problem with the blockade, because we have to find the real things needed to do PCR tests in different parts of the world, because it's very difficult to find. And the positive the positive test among all the people is just 0.82%. Means that it's very low. The WHO is talking that about if you have more than 5%, you are in a big problem with the outbreak. But now we have 0.82. Okay, this is one thing that I want to show you because it's a research in progress. We are looking at what is happening with the living condition index and with the number of PCR tests per million inhabitants. The line of the red line is the how many PCR we performed by 1 million inhabitants using the international indicator for these things. And you see in Havana is the capital. The incidence is higher, but the incidence is higher. We are doing more tests, and you will see in this. But the good example here is that if you look at the image, for instance, the lowest living condition have less cases than the other scenarios. But it is just new that I am just sharing with you because this research is ongoing. But the idea is just to show you how we are working, not just with the COVID itself. We are looking at another situation related with equity. That is very important in this disease. Okay. Well, this is one thing that we are calling the STARS. Means what is the preventive and therapeutic action from the screening to full recovery of the patient. We are working with 4 types of items. It's the healthy population, the confirmed patients, the serious and critical patient, and the convalescent patient. What is the Cuban approach? The first is that the healthy population not get sick. If you are confirmed as a patient, not get worse. If you are a serious critical and critical patient, not to die. And if you finally convalescent from the disease, less in long term to avoid the side effects. That is the idea that we are working with. And if you see what you are doing with the healthy population, we are doing, as I mentioned before, active screening, self-screening, biotech preventive treatment. And this is a good news that we have because we are working with our products from the biotechnological industry in Cuba. Because when this thing started, and they said, well, interferon is good, we were producing interferon in Cuba. That is a very good thing that I want to share. And the second, with confirmed patient, we have a protocol for the treatment. But the thing is that this protocol, we are using innovative treatment from our industry. We are calling about 80% of the treatment that we are using with the patient belongs to the national industry. And this is a very good news for us, because for now, with this type of treatment, we are avoiding many things that we have with the blockade, as I spoke before. And if the people are serious or critical, we are using a lot of immunomodulators to prevent the complication and even to prevent that the people die because the COVID. And after that, when the patient finishes the treatment and is in convalescent situation, where we have surveillance because we are following the patient during time, where they need a psychological support, rehab, regenerative therapy, and follow for different specialties. It means that, you know, after that they need support for not for just for clinical people, they need support from other specialties. Well, this is the approach I mentioned before. This is a Cuban population, 11,200,000. We have this is the people that we're working with as a risk, the health worker in the red zone, the intensive care unit, the dentists or ophthalmologists, and primary health care. The social institution that you know, all of you know, that is the nursing homes was a problem, and it is a problem in different countries. Spanish is one example, and we are working with all social institutions, and also in the general population, we have a stratification of the risk by territories in Cuba, means province, means municipality, and means popular council, that is a smaller government in the among the municipality. And they have this is a intersectoral approach that we are working. And also we have the selection of individual. When after we select the territory, we select the individual by age group, because all of you that this is a risk, and number of comorbidities, hypertension, diabetes, etc. Well, and this is one example. For instance, if you see the column with the aging index, the aging index in Cuba is not the same in all the provinces. We have provinces with very high index, like for instance, Villa Clara in the center of the country. And what we are doing is we have the drugs, we have stratification, and we are preparing where we have to make prioritization of the treatment, of the different treatment, and the approach and the risk approach in different countries. And this is just a map, but this map you can find how many people you have with hypertension, with the heart disease, with diabetes in each municipality, even in the popular council. Okay. Well, this is the vaccine. You know that we are working in 2 vaccines nowadays. This Soberana 1 is we have a clinical trial. The clinical trial is working well. This is one example of a clinical trial. Speaking with the volunteers that they are receiving the vaccine, and this vaccine is working well according to the person and the people who are working this vaccine. They expect it to be finished in the first part of year 2021. This is good things. But now we are yesterday we started with another vaccine. This is Soberana 2, and this is another. I have to say that today we are working with 2 possible vaccines. That one of them we will find in around March of 2021. Okay. Well, this is the lesson learned during the COVID-19 up to date. It means that the things is changing, but the thing that we were doing was working from the beginning with the preparation. It means when WHO notified the situation, the action was, the first is political will, that I spoke before, the prevention of the control of strategy that we make, the government wrote a plan before we have the first case, and to organize everything, and also the human resource preparation that I also spoke before. The epidemiological surveillance was a very important dimension, facing the unknown of the disease. At the beginning, nobody, even today, the people, we have not the comprehensive view that what is happening with with COVID and what is going to happen with the SARS-CoV-2 in the future. And we have that gave to us to prepare and develop epidemiological surveillance system with the key points to identify risks, as I mentioned before. And active screen, I spoke about that. I mentioned that the highest contagious disease, the unknown prevalence of the population, and also action about the primary healthcare system, early detection of decay, isolation, critical forms and high-risk group identification that I mentioned before. Okay, sorry. Well, this is testing. I mean, testing is with the PCR, and anyway, we are working with a new test with antibodies that we will finish to use with the Cuban technology. It will be finished around 2 weeks from now. And the other thing, but we are working, is all the case are the diagnosis of a case is by PCR, no way. Now this is another thing, and also we are working with antibodies that we will see what happens in the next 2 or 3 weeks. Well, biosafety, because the problem of the virus, and I spoke about the thing that we are working with the health care people, what we are doing to provide a good equipment for primary health care, because they are not working direct in the red zone, but they are working on that. And the treatment I mentioned before, and mortality I mentioned before as well. And finally, we are spoke about equity. This is very important in the health Cuban system and the Cuba as a country, that the equity is a principle, and we are trying to keep the equity, the government, and we in the health system are doing the same. How guarantee that all healthcare servers are equitable and avoid collapse of the health system. And we do intersectoral actions, keeping health service universal and free. All these services are free for everything. And reordering the increasing of healthcare service capabilities, and testing free, and control and follow up of the confirmed and suspicious case. And finally, the Cuban response in very few words to the epidemic has been among of the more successful in terms of flattering the cure and limiting viral transmission in a relatively short time, resulting in relatively low case number and deaths. I show you everything about that. A strategy, particularly in Cuba epidemic response, including building on the universal character of the health system and is strong, I have to mention strong in capitals, primary healthcare network by carry out nationwide door-to-door screening for persons with febrile and respiratory symptoms, isolated confirmed cases, and placing their traced contact and suspected cases under quarantine. Finally, early inclusion of research and scientific institutions in the design and structure of the strategy. This is what, well, thank you very much. And I think that I have not spent too much time in the presentation. I just trying to show you what we are doing, but there are many things that we have to mention, maybe in another opportunity, or maybe some of you have questions. I will try to answer. If not, I will try to write you some of them. Sorry about the time, but I was to try very short.
Thank you very much indeed for that presentation, Professor Más Bermejo. That was wonderful, and you were perfectly to time, so no apologies needed.
Awesome.
I think clearly there are very many lessons that we can learn from the Cuban case. And I was particularly impressed with the slide that you showed on the preventative and therapeutic actions with the population divided into 4 groups, from the healthy population to the serious and critical patients and so forth.